Please do not forget to fill out the evaluation form, and the link is posted in the chat box. To continue this lively discussion, we have the Philippine Orthopedic Wound Care and Diabetic Limb Society to be moderated by Dr. Jonathan Ronquillo and Dr. Roberto Lopez.
Can, can everyone hear me? Hello. Hi, good afternoon to everyone. Thank you very much for being here and to listen to the OCDLS subspecialty. Today, we will be hearing from distinguished lecturers from our field, sharing their experiences when treating chronic wounds for the past 2 years. We will hear one from Cebu, from our colleague from Cebu, from Dr. Mella, and another is from Butuan, from Dr. J. Asuncion. After that, we will be hearing from the innovator or the maker of Coco Patch, was Mr. or Sir Denver Chicano. No? Dr. Chicano is a graduate of the nursing and was awarded the International College of Surgeons Special Awards for wound care product for the underprivileged, wherein he also got top 5 green innovation products of the Philippines from the Department of Science and Technologies. Then after that, we will be hearing a case from one of our colleagues from East Avenue Medical Center from Dr. Mendel Gatchalian. Thank you and hope you enjoy our special lectures for today. Thank you.
Paano yung background? Ang background natin ano? Hindi, nakasit pa nakaset ang background ko. Nakaset na yung background nila. Hindi, yung background natin kung ito.
To start with, I have to share that we had a very difficult time treating chronic wound during the pandemic. Why? Because the problems we encountered were not just at the OPD. It was how we refer our patients to other centers such as the Diabetic Center, the Wound Care Centers. So we had to come up with a way that we can still manage our patient even outside the hospital, or if inside the hospital, we were pretty much doing it in a safer manner and with lesser transmission of the COVID virus. So with this one, we tried to come up with our own algorithm for chronic wound. So as soon as patients arrive at the OPD, they will be asked and undergo a triage system, and if they have the symptoms, immediately they will be sent to the ER. So with the red flags that we see here, we mean the necrotizing fasciitis kind of wound. So if we think that there is an underlying sepsis going on, we immediately refer to the ER. So if you can see in our algorithm, I incorporated the use of teleconsultation for follow-up, and it has helped our center a lot for monitoring our patients. So with this one, I'd like to share some of our cases. So this initially consulted me through Facebook. The doctor explained to us that the patient was already paraplegic and she had an MRI done in Bacolod where there was no treatment done since the patient refused to have treatment. With this one, the family sent me this picture. It was a grade 4 sacral ulcer. With this, initially, we identified the problems of the patient. So she had all these red marks as a potential problem leading to sacral ulcer. These were the treatment immediately given through Facebook. We advised them to turn to sides, passive range of motion, shift to Foley catheter so as not to soil the diaper a lot. And then we asked them to buy a TLSO brace for the fracture of the spine so that the patient can be moved as often as every 2 hours. And then we advised them to have an advanced wound care treatment for the wound. So what we did was a home visit for the first debridement, and we cleaned out everything. We tried to oppose the skin as much as we could to decrease the size. There was control immediately of the foul-smelling discharge, which spread over the entire house, as claimed by the daughter. And this was on day 7 of the consultation through Facebook. If you can see, there's improvement of the granulation, and on day 14, this was the status of the wound. Unfortunately, a month and a half after the first debridement, patient did not seek consultation for IV antibiotics as we have discussed, and she refused any treatment for the cancer. So patient expired. So for this patient, this was our wound care protocol. We asked them to wash first the wound with microdacin solution. We don't need a lot during the procedure. We just have to spray, soak it a little bit, maybe 5 to 10 minutes, and then remove it. We put iodosorb, and then we cover with a gauze pack, and then put a sterile dressing on top so as not to soak it. This next case is interesting. 54-year-old female non-healing wound for approximately 3 months, and her daughter messaged me on Facebook saying that they'll amputate the leg. So she underwent 5 debridements, and for this they tried to ask if we can still do something else. So I guess with this one, we immediately we transported the patient from their province, and this was our finding during the first day. I tried to do an extensive debridement. I initially saved the tendon of Achilles, opened it. I saw that there was already pus inside, so I drained everything as much as I could. On top, to save the tendon, I put a vac. So on the second day of the OR, we did further debridement, wound exploration, and we can see here that the tendon of Achilles is already involved in most of its part, and there was necrosis already. So I was pushed to remove the Achilles tendon instead of leaving the tendon there. In hindsight, I think this was the main problem with the 5 debridements that was done. And initially, I thought maybe they weren't able to control the infection at this point. And so we did a vac after, and comparing it with the previous surgery, with the TA there, we couldn't put the foot in a neutral position. It was a plantigrade position. So this actually helped the patient. And this was already done at our wound care center. Imagine on day 12, patient with very good granulation. Immediately after that day, we improvised our vac. We applied it just at the OPD. And on day 30, still there was good granulation. However, we don't want to risk having a skin graft. For that case, we tried to discuss with them, and so we applied microdacin again. And if you can see here, there's still a little bit of Achilles tendon exposed. We are running the risk of drying it and probably leading to infection. So we suggested for microdacin hydrogel to keep the moisture in there, and then cover it with foam dressing. So patient would normally come in our clinic once a week, and the family knows how to do the dressing and would send us pictures through Facebook. This was at day 42. If you can see, the wound is getting smaller, but with this one at day 42, it was the slough that we have to remove all the time. Okay. And this is the first time that our patient was able to walk after 6 months. Okay. So she had a very hard time on the first 3 months in their province. And here with the vac in place, she wasn't able to move around. And exactly at 6 months, she's happy. And with this one, at day 77 in our wound care center, we inspected the wound and we sent her back to her province, and then just updated us with a wound status. Okay, this is my third case. So this one is a 51-year-old female with sacral ulcer, back pain, and weakness. She had a very uncontrolled diabetes, and she presented to us with an acute spinal cord compression with a diagnosis of an epidural abscess. Initially, we thought it was tumor, but then we immediately brought the patient to the OR after 4 days because we had to have clearance. She was septic. And so with this, we saw we just removed part of the lamina. We didn't go all in immediately. We checked and we aspirated the abscess. So we didn't have to break everything, but instead inserted the abocath, the soft part of the abocath, and aspirated the abscess. And we washed it with microdacin again, soaked it for a little while, and uh, we had a hard time putting the patient in a prone position since she was very obese. So with this one, I think the next thing that comes to our mind is how will we position her? So lo and behold, we have a sacral ulcer at exactly a month after the surgery. So this was her positioned again with all the guys here in the OR helping us position since we had a difficult time putting in spinal anesthesia. So with this was exactly 50 days post-op. She was able to stand now. The wound is like this. So basically what we did was a flap, and still, even if she tried to manage her bed turning because she's quite on the very heavy side, so she still ended up having the skin breakdown. So we tried to advise them in their house through Facebook, just give us the update of the wound. And this is her. I did a home visit 3 times, and at 90 days, they said, "Naayo na." So it's already healed. Patient is happy. Patient can stand up. This next case is a 54-year-old male with a complete spinal cord injury. This was a service case wherein a month ago, patient underwent a posterior decompression over the L1 and instrumented spinal fusion from T11 to L3. Patient developed, since a month after the surgery, patient developed sacral ulcer, followed up at our OPD in the wound care center, and the resident just did serial debridement, 3 sessions of negative pressure wound therapy, and this was the status of the wound bed on the second month. So with this, finally, after 150 days, the granulation finally closed. Okay. And if you have to compare with the previous patient that I did, this was 90 days only. In fact, this patient had a bigger wound initially compared to this guy, but with the flap, it helps in decreasing the amount of time for healing. So I would suggest probably if you can flap, you have to flap, you have to close partially, try to decrease the wound. Don't just wait for granulation to kick in. With that, so as a take-home message, advanced wound care treatment can be done in a hybrid manner. It can be done inpatient, outpatient, in wound care centers, even home visits and teleconsultation. You have to be always ready to adapt and improvise in terms of practice and follow-up of your patient, and know the technologies around you to maximize the wound healing. And also, never give up. Don't resort to amputation immediately. Know the possible options available. Again, this is our wound care center here, and I think we got away with COVID once it was the peak because of this small electric fan blowing outside. Nobody from the wound care team had a COVID-19 during the entire peak of the pandemic. So I'm very happy. And with this, and lastly, I would like to thank this guy who taught me how to manage wound in the best possible way. Thank you so much, Dr. J. Asuncion. Have a pleasant day, everyone.
Thank you for that lecture, Pierre. Unfortunately, at this point, we're not able to include the lecture of Dr. J. Asuncion. But for our next lecture, I would like to introduce again Mr. Denver Chicano. So Denver Chicano, who will be talking about the Coco Patch. We received numerous awards for this innovative material, including the International College of Surgeons Special Awards, Top 5 Green Innovation Products of the Philippines from the Department of Science and Technologies, and even got the first place in most creative research using the cocoa cellulose wound dressing. Currently, Sir Digoy is a research development head for the PatchMed bioengineered cocoa cellulose technology. Can we play Sir Digoy's lecture? Thank you.
Hi, good morning, everyone. I'm Denver Chagano. I would like to introduce to you a wound care product that is developed and manufactured here in the Philippines, and we call it Coco Patch. I'll just share my screen and show you a short video about the product.
Legendary tales of the comforting and healing powers of the coconut fruit have come far and wide. Now, another byproduct of this natural wonder brings a whole new level of comfort and healing from the Philippines, across Asia, and now in North America. Coco Patch offers a better way of managing pain from burns, lacerations, abrasions, and it's proven best for pressure injuries. This all-natural, hypoallergenic, moist wound dressing made from cocoa cellulose fiber, impregnated with monolaurin, has profound antibacterial, antiviral, and antifungal properties. Apart from its cooling effect, Coco Patch also acts as a barrier against bacteria causing infections and provides autolytic debridement that aids in the skin's natural healing. Coco Patch has moisture balance capabilities to minimize damage and keep skin intact, preventing skin maceration, Clinically proven to be cost-effective and safe, Cocoa Patch has become one of the most trusted partners of healthcare workers, families, mothers, and patients in the healing of painful skin injuries worldwide. Feel better, heal better with Cocoa Patch.
Yun. Uh, that's the product. It's basically made from coconut. Kaya Pinoy na Pinoy. And we chose the material itself because coconut's very abundant uh, here in our country. So this is the only advanced wound care product made from a quality natural component that acts as a protective barrier from infection, that suits the pain when applied, painless when removed, and has a moisture balance capability that aids for early wound recovery. So as as our practice as wound care practitioner, minsan nag-iisip tayo ng solution for the problem, which is kadalasan sa mga pasyente natin is yung pain, ano yung produkto na pwede for pain, na ma-address niya yung pain, yung moisture, yung protection, and also exudate and infection. So kaya nag-mix and match tayo, like we're using antibacterial ointments, gauze, or other specialist dressing na lalagyan mo natin ointment. So we sought for a solution to come as one. So the technology was developed in 2007. I was a burn ICU nurse in Pinjero Hospital. Doon ka na-start ano yung idea. And I've seen all the patients na may sugat. Basically, the problem is yung gastos at saka sakit. Yun ang kadalasan na nakita ko na. So, I developed the product na ma-address yung basically comfort and convenience ng pasyente. So it is a breakthrough wound care product na na-address ang pain, moisture, and protection in one product. So we are trying to reinvent the gauze, the usual thing, yung inaano natin, yung hindi naman lahat ng tao. Alam mo yung mga specialist in dressing. The usual standard is ointment and gauze, ointment and gauze. But yung mga talagang alam na yung mga advanced wound care products, I mean, especially doctors, yeah, may mga hydrocolloid na, may mga alginates na, may mga foam dressings na. Pero sa usual setting ng ordinaryong tao, gauze and ointment na sila. So we want to reinvent the gauze language. Cocoa Patch soothes, cleanse, and protects the wound. Pag makikita yung para siyang gelatinous material. Yeah, it's a gelatinous material, but it has a high tensile strength. Kaya pag tinanggal siya, at hindi siya napupunit o yung naiiwan na particle pagdating sa sugat. And it's three active ingredients or ingredients of Cocoa Patch is cocoa cellulose, monolaurin, and water. Water basically is the best moisturizing agent na pwedeng gamitin natin as also acts as a delivery vehicle for active ingredient. And the active material na ginamit namin for device preservative is yung monolaurin. Monolaurin also is derived from coconut and it has antibacterial, antifungal property and recognized as US FDA and as GRAS or generally recommended as safe. Yun yung pinaka main ng material is the cocoa cellulose. It's a Philippine variant of bacterial cellulose, which has a properties of ideal wound dressing. It is a higher breed ng nata de coco. Like nata de coco, pag chino mo na punit, this one, medyo mas high sa fiber content siya. Way back before 2007, the technology was really new, but now there's a hype of other countries developing such product, like sa Germany, Canada, yung mga bansa pa na malalamig at walang coconut, they're the ones developing this type of product. Kaya pagdating sa atin, nata de coco's food, but for them, it's a biomaterial. And our company started the use of this cellulose as for medical application. So the product itself was also tested in Department of Science and Technology that in standard testing center that Cocoa Patch inhibits the growth of Staphylococcus aureus and Pseudomonas aeruginosa. Yun yung isa nung experience ko sa nasa burn unit. Pag may Pseudomonas, yun, nakakatakot na yun para sa pasyente because of yung scare infection. Yun, nag-e-time na. Yun, yung panahon na naalala ko na. So, the mechanism of action of cocoa patch is it provides moisture to the wound and it absorbs the exudate. I'll show you a video kung paano nangyayari. Parang napaka-creepy, no? Paano nag-hydrate at nag-absorb yung produkto or yung material. It has a different properties or advanced property other than the material used in dressing. It has an ergonomic property. It attaches directly to the tissue. Katulad ng one of our patients who has squamous cell carcinoma na tinanggal, kaso wala silang pambayad for skin grafting, pinukupatch na pinukupatch. And kita yung ergonomic property niya, lumala pa talaga siya sa wound bed. And there's another picture also na ang hirap i-manage, especially for mga bed sore. Wala tayo iba ulit. Kadalasan, bakings, no? Bakings or ointment, pero nalagyan mo ng ointment na ganyan kalaki. Ang hirap, parang nagsayang ka na ng ointment. And other products, okay naman din, but ito yung pwede mo siyang ipasok sa loob ng bed. Lalo pag may mga tunneling nakita sa patient. Like this patient, this a grade for pressure ulcer. In September 25 siya, and ito na yung sugat niya ng February. Actually, we have done this, pero tele-wound care lang to siya kasi hindi siya from Manila. Taga-Visayas siya. So, ang ginagawa namin, me and my wife do also have a wound clinic, na pinipicture nila, we send it to us, tapos i-instruct namin sila kung paano dapat gawin. This is post-debride na ginawa na sa probinsya. So, after how many months? 5 months, ito na yung sugat. And cocoa patch also have the moisture balance capability. Makikita nyo sa side, sa scalp burn ng bata. Nakita nyo kung saan yung whitish part, please to say, may sugat pa siya. Moisture pa rin yung cocoa patch. Pero as the wound heal, natutuyo yung patch. At pag tinanggal siya, yung mga newly utilized tissue, skin, hindi siya sumasama. Naiiwan siya, na-preserve siya. It has also autolytic debris property. Ganito, S-car, hirap tanggalin ng ganito. Pag usual, dati naalala ko pag saan, kinakayod namin yan para matanggal. But with the use of cocoa patch is 3 days after application, yun, ano na, yung S-car na, which is biofilm, na nadurog, nasipsip na cocoa patch. So this is the video of non-adherent property of cocoa patch. Hindi siya dumidikit pag tinatanggal kasi kadalasan pag sa mga practice natin, natanong yung pasyente, masakit ba yan? O isan ayaw na lang nila magpaano dahil yung natotrauma na, especially pag mga bata. Ang hirap i-manage ng mga bata. Parang they're so traumatized pagdating sa wound dressing. Kung may lalapat, we do have experience na may dadligan na bata na merong actually accidental na tinamaan siya ng ligaw na bala, na paralyze siya. Tapos yun ang laging tanong niya, yung bedsore na yung masakit ba yan? Yung tatanggalan niya siya at least na is makukupas. Nasagot yung need ng bata, which is the comfort. So, pagkukupas is very economical. It's 3 days before changing. So, pag-develop din namin ng product, we also look for the avenue kung kakayanin ba ng pasyente. Diba? Like us, sa mga pasyente natin, tinitingin natin ng pasyente capability nila to have a successful treatment plan. Kasi budget ang kailangan ng pasyente. Once nagkaroon ang family ng problem na ganyan, or isa sa family, everyone in the family is involved. Kasi yung una-una, budget. And Cocoa Patch saves time, materials, resources, and non-tedious siya gamitin. So, for test na ginawa rin sa Cocoa Patch is considered hypoallergenic. Actually, it's all coconut based. Pwede siyang makain. Pero hindi natin sasabi na try nyo kainin. Pero pwede siya makain. Edible po siya. And the methodology directly tested as non-irritating and safe in Cocoa Patch. And the first study before with Cocoa Patches was compared with silver sulfadiazine in APR Burn Center. Ang conclusion of the study is locally produced microbial cellulose is significantly more efficient than silver sulfadiazine in treatment of superpartial induced burns in terms of number of days to complete revitalization, and was found to have lower VAS score both at rest and during dressing. Yun ang isa na tinarget namin na ma-address. Yung pain. Masakit kasi sa pasyente ang pag yan, burn or nagkaroon ka ng gas-gas, yun talaga. It's very traumatic for them. Lalo pag tinatanggal na yung dressing. And sa study, mas less ang pain niya. So there are also clinical evaluation done in Zamboanga del Sur Medical Center. Kasi way back pa to na ginawa Dr. Ampong and Dr. Talit Lucero. All those specialists in dressing are not available sa probinsya. Hindi pa noon available. Pero yung standard na ginagamit nila, bilhin ng ointment, lagyan ng gasa. And this is, ginawa nito sa ER setup na yung pasok ng pasyente na dito, kung pakupas na gagamitin, kung pwede ba siya. And which is, it yields a promising result na regards sa healing, saka sa gastos, kung sa gastos ng pasyente, nagiging mas mura sa pupupas kasi hindi siya araw-araw para pumunta sa ospital for wound dressing change. Ginawa rin siya ng clinical evaluation sa Philippine Marines for neglect to burn kasi nangyari yan before. Bawal sa kanila may tattoo, yun ang kanya-kanyang, hindi sila ma-re-enlist, kanya-kanya silang tanggal ng tattoo. And eventually may nangyari na-infect. Kasi maski may ganyan ng mga sundalo natin, hindi pa rin pwede, teka, leave mo na ako, hindi. Hindi ganun sila. Maski nasa battlefield ka, papadala ka nila. Ganun ang sundalo. Baga, yes sir lang talaga sila. So, na-evaluate ko to batch, it's good for the battle, sa battle dressing. Kasi different setup, lalo na pag na-deploy sila sa kagubatan, iba-iba ang environment, putik, ito ganyan. Pero pag may nakalagay na patch, is na may maintainers, it prevents the non-fibular structure ng Cocoa Patch, hindi pumapasok yung mga microbes from the outside environment sa wound dressing. So, the cost efficacy of Cocoa Patch with GOS and SSD is medyo malaki. No? Una-una, yung sa dana study na mga dunas clinical trial sa PGH is ang size ng, it was before, 3x3 pa lang yun. Pero right now, Cocoa Patch is 3.5 by 3.5 inches. So, 646 ang gastos for 3 days pag Cocoa Patch ang gamitin. Pag yung standard of care na ginagamit using silver sulfadiazine ointment is 1,572 on 3 days sa 1% total body surface area. So, mas mura pa rin pag sa Cocoa Patch. Hindi nga tedious kasi hindi mo araw-araw tinatanong. So, the price comparison with Cocoa Patch and specialist wound dressing, medyo mababa kasi because of dito manufactured yung produkto, and as well as it has more benefits than the usual available products in the market. So our company is PatchMed. We are the first biotechnology company focusing in wound care products. So in everything we do, we believe in importance of patient comfort and healthcare convenience. Our wound care technology focuses on the challenges of serving different status quo in wound care management. Yung talaga pinaka-importante kasi yung mga dressing available in the market right now is designed abroad. Hindi siya designed dito sa atin. Kaya pagdating ng cost dito, mahal. And lalo pag nasa class BC, hindi talaga ma-afford yung mga product. Like pag mga kailangan talagang mga advanced wound care dressing ang kailangan nila, nahihirapan sila na ma-afford. So the way we are challenged is by making our wound care products available, affordable, adaptable, acceptable, cost-effective, and simple to use. Kasi sabi ko simple to use kasi in every time na magkakaroon kami ng patient and also pinaka-importante is yung health teaching, yung teaching nila kung paano nila i-dress, kung paano yung ganito, ganyan, ano yung time na dapat sila magsabi, bumalik sa doktor, and kaya ginawa natin yung product na simple to use, na walang A and B. Ilagay mo siya, linisan mo, ilagay mo siya, ini-anchor mo. That's it. Yun yung ng produkto. And it's our passion to make great wound care products to make the patient feel better and for them to heal better. So, yeah, the other technologies that we have developed is with bioengineered process technologies. We do have the film, we do have the patch, the plain patch, we have the gel, and we have the perforated. And ito, may mga story kung ba't ko dinevelop siya. The patch is, nasunog ang mother ko nung nasa PGH ako, and sinave siya ng tauhan namin. So eventually, he died because of 80% burn. Pinatak niya yung mother ko, siya ang napuruhan. And yun, una ayaw niya maniwala na pwede yung produkto, yung natagito ko na hinybrid ko, na gamitin for wound dressing. Pero eventually, nalusot ko na, okay, nagamit niya na shooting for her and also third degree sa daliri niya, sa buong arm, right arm niya, buti hindi siya naputulan. As pleasing as itself, yung keloid formation. Yung gel naman, dinevelop ko siya because of my father. Nagkaroon ng pa-stage pa lang ng lump sa throat ang father ko na tinanggal, may radiation therapy siya. And nababurn yung neck niya. Una, naano ko yung nagsusulat yung coco patch pa, sabi ng tatay ko, paano mo, ang hirap naman, sa leeg, kaya ginawa ko siyang spray gel. And this perforated is yung sa kaibigan ko na I'll show you the picture later, na infected yung wound niya, na diabetic siya, na pwedeng maputol yung paa niya. Parang sa brother, wala tayong ibang klaseng wound dressing na pwedeng tapal dyan. Ito gamitin natin, which is the perforated. Kasi kailangan mag-push out yung mga exudate na lumalabas sa sugat mo. Kasi magang-maga yung sugat niya. So, this is the product of this is the wound of my friend. We use Vermac for that. So, wala naman itong focus, hindi siya pwede focus kasi magmamasa, katas na katas yung sugat niya. And that's why I developed a perforated. And this is after 9 days. Itong picture na to. It's 9 days from application. Kumbaga 3 times pa lang nag-change ng ang dressing niya. 3 times pa lang nag-change ng dressing niya. Ito na yung itsura ng 9 days. Pero syempre, guided din ng doctor, may wife's doctor, he's a surgeon, and specializing sa wound care. Antibiotics pa rin ang pinaka-importante. And especially, control dapat yung sugar niya. So, these are the products, and ito yung Coco Gel. Ngayon, there's a study, ongoing study in Philippine General Hospital used for cancer, radiation, cancer undergoing radiation therapy. As of now, yung mga result is better, and inaatay pa namin the whole completion of this study. So, maraming salamat with your time, and bayanihan tayo sa paghilom. And hope you'll support the product. This is proudly Pinoy. Team nga ng convention ng Philippine Orthopedic Association is hitting at galing. This is a proudly Pinoy product, and hope you'll support it. And this is a product that we can be proud of as being a Filipino. Thank you very much.
Okay. Thank you for the lectures to both speakers. Now, we will open the floor for any questions, and I would like to welcome Dr. Jonathan Ronquillo. Thank you very much, sir, for being here, for being a reactor and moderator for this session. But for the first question, I'd like to ask both lecturers, Doc Pierre, hi, welcome, and Sir Denver.
Hi.
I know both of you have wound care centers. Now, our topic kasi is about how we dealt with the COVID situation. So, when we treat chronic wounds, the patient must be present. So, how difficult was it on both of your sides? In your area, how did you treat these patients? When will you advise them to come to your clinic, or when will you be satisfied with just looking for the pictures and sending it to you?
Yeah, sir. Can you please go ahead first?
Denver, maybe you could start.
Yeah. Actually, what we have done is we utilize mga social media like Messenger. That's why yung mga pandemya, yung nagsaraming pandemya, we have a lot of patients, hindi lang dito sa Metro Manila, but also sa Visayas sa Mindanao, because we do have a satellite wound care center sa Mindanao. We utilize the social media, yung Facebook page. That's why we created the Alpha Wound Care Facebook page para yung mga inquiries nila. Every time that they change the wound dressing, pinipicture na lang nila doon. Tapos we assess it. Tapos kunyari may kailangan ng mga debridement, saka namin pinapupunta sila. Pero we have also trained mga wound technicians, tawagin namin sila, na kunyari kailangan ng debridement ng bahay lang, pinapupunta namin sila. Pero pag mga kailangan talaga ng doctor for debridement na talaga, yun, that's the time na kailangan namin sila papuntahin. As well as yung mga laboratory nila, pinapaano namin yung mga labs nila, tapos nasend na sa amin. Tapos binabasa yung lagi ng misis. Every time, every morning, yun yung mga inaano, bago siya mag-start ng clinic. Ayun po, no.
Thank you. Pierre?
Yeah. Hi. Thank you for the question. So I think I presented during my one of the slides. We incorporated the walk-ins and our ER patients as part of our workflow. So before we opened our wound care center again during the pandemic, we made sure first that the ventilation is well adapted. So we placed fan going outside, and then we tried to attach some form of ducting, but it was too impossible. So what we did, we screened the patients first through online, and if there are signs that our patients have necrotizing fasciitis or going into sepsis or need a very fast amputation, then we ask the patient to go to the triage, and then that's when they enter the wound care center. After the debridement, if we think that the patient doesn't need too much of debridement the following session, then they will follow up using probably a social media account. We use basically the Facebook, because most of the patients, even in the provinces, have the social. So basically, it's a hybrid, not pure online for us.
Okay, so Pierre, it's more of hybrid for you.
Yes,
right?
sir. Yeah.
Okay. Follow-up question, my personal view lang. Personal question. More cases became severe or less? Like, for example, did you see more cases na naging severe because of what we were trying to do, like hybrid, or was a better option at that point?
Actually, during the start of the pandemic, it was the hybrid approach of it was better for the day to the wound care center, and then our wound care center nurses can update immediately the doctor whether the wound was getting better or not, or they have to come in earlier. Before, when we did not utilize the online, we would wait for 1 week before we see our patients from the far-flung provinces. But with the help of the messenger, it was very easy for them to just upload a picture. So basically, we use this one even in our ICU setting because we saw that there was a high rise in the sacral ulcers in our hospital during the pandemic. So we asked the nurses to just upload and send to their co-nurses, and then we try to manage the wound from there. So we don't ask our wound care nurses to immediately go to the ward, to the ICU, and check on them one by one. So in effect, it's really still hybrid.
Yeah, so looks like it's better at that point.
Yeah,
So,
yeah.
Since you're there, Pierre, no, there's a question from the floor. I'm just gonna read it. I think it's for your second case. The Achilles tendon. I think it was for the Achilles tendon. Yeah. With the second case, when is it safe to do range of motion of the ankle?
Okay, good question. For that one, we shifted the patient immediately around, I couldn't remember, but as soon as we were able to get a plantigrade and the wound was very okay, as soon as there's good granulation already and you're happy, then you can start doing range of motion. Because the problem here with the PA is when you try to make the patient ambulate and do range of motion, the skin will break down again. So before I ask the patient to do range of motion, the granulation has to be very okay, rigid enough. And since we did not put a skin graft, then that one is really dependent on the wound healing of the patient. So you can't really say a fixed number of weeks before you can start your range of motion. It's the assessment of the wound care team, including the doctor, whether he's confident to do range of motion. And since in my case, I removed the tendon of Achilles, technically I was just waiting for I hope I answered the question.
A bit choppy at the end, but I think you gave a good answer for it. Now, I also have a question from the floor for Sir Denver. Yeah, there is a question here. Where can they order or buy this Coco Patch?
Actually, you can order sa Coco Patch Facebook page. Tapos sabihin niyo po pag doctor kayo, tapos we give a special discounts for doctors. Yun po. Facebook page basically. Or tawagan po ako. I could give the number later or post na lang po sa chat box.
Yeah, even do sa Facebook page nyo, no, you have this Coco Patch Facebook page. And then
Yes,
they could
po.
see the details. Now, there's
Yes.
also a question na, can the Coco Patch be combined with other methods like negative pressure dressing?
Yes po. Actually, you could combine it kasi yung kadalasan dati pag para tool dressing kaso pag nasobrahan ng pagtanggal mo dikit, nagbi-bleed. Pero with Coco Patch hindi, yun yung difference. Pero it's not Coco Patch but Vermac, yung perforated. That's better na mas ginagamit siya for negative pressure like sa heart center may mga gumagamit ng Vermac for mga home, mga Curabac na pinapahiram nila. They're using Coco Patch for that.
Okay. Thank you very much, guys. Due to the lack of time, May we suggest that the speaker stay, and we will let Dr. Lendel Gatchalian present the case. Doc Lendel.
Hello, Tubers. Can you hear me?
Yes, Boss Lendel, you could go ahead.
Okay, so thank you very much to the two previous speakers. So very enlightening lectures. No, so I was tasked to present a case. Basically, this is a morbidity, that was suffered, no, during the pandemic also. So my disclosures are as follows. No, I am not receiving any compensation for this. No, I just accepted this talk because friend ko si Dr. Tubers, and the patient consent was gotten for this presentation and discussion, including the pictures, the patient data, and the assurance of anonymity for the patient. So what is the case? No, this is a case of a 36-year-old female uh, who got into a motorcycle accident. She was a back rider of a motorcycle. When they got into accident, her left heel got caught in the wheels of the motorcycle. So the wheels were still spinning when they fell, and then her left heel uh, got caught in the wires of the motorcycle wheel, the rear wheel, and was immediately brought to the emergency room. And these were the actual pictures at the emergency room. No, and we could see that there is a large avulsed injury of the left heel, no, the heel pad, and we could see that there's also part of the calcaneus that is already showing. And on X-rays, no, we could see that a chunk of the calcaneal tuberosity has been avulsed, no, and this patient was then there was also severe contamination, and the Achilles tendon was traumatically ruptured, and there were a lot of non-viable tissues. Fortunately for the patient, no, there were still good distal vascular supply. No, the pulses were present, and there was still good capillary refill on her toes. There were also no neurovascular uh, uh, findings, no, on physical examination, the ER. So what was done to this patient? No? This patient, the emergency room, antibiotics, triple antibiotics were started, no, covering for all gram-positive, gram-negative, and even anaerobic coverage was started. And then general cleansing and dressings were done at the emergency room level. Then this patient was brought to the um, operating room, and we did radical debridement. No? We noted that there's the loss of the calcaneal tuberosity, and the distal Achilles tendon was so macerated. And then there were a lot of skin and soft tissue loss. The heel pad was debrided, and uh, some skin was still left, no, to try to save it if possible, or just act first as a biologic dressing. And then this was dressed with silver impregnated foam dressing, which was the only thing available at the operating room at that time. And then after which this patient underwent a second look debridement, and then subsequent serial debridement until we were able to get a very clean wound, no? And this patient was then prepared for reconstructive surgery. So at day 11, no, we did a reconstruction wherein we did initially Achilles tendon lengthening procedure, V2Y lengthening procedure, and this the distal part of the Achilles tendon was anchored and reconstructed and connected to the remaining calcaneus using suture anchors. And then for coverage, what was done was a reverse sural flap, as you could see here, to be able to cover the defect at the heel. No, incidentally, the heel pad, the skin of the heel pad was eventually debrided off also because it was non-viable, became non-viable, and so we had to cover it with a reverse sural flap. And for the donor site from where we got the sural flap, we covered it with a split thickness skin graft as seen here. Okay, so this is our coverage and reconstruction of the Achilles tendon. So unfortunately, the fourth post-reconstruction day, the sixth post-reconstruction day, we noted that the flap started to discolor and eventually became necrotic. So this was eventually taken down. So the flap was removed, and we did a debridement, and then at that area we just applied negative pressure wound therapy, and this NPWT was continued 10 days post-op, and then the patient was eventually discharged because financial constraints. Patient wanted to try to use the negative pressure wound therapy at home, so it was continued 20 days when the patient was at home. Okay, and updates were done via teleconsultation. Again, like Facebook, because it is the most available, and Messenger. So that's how we did our teleconsultation. So wound care was done at home eventually after the 20th day on negative pressure wound therapy. The wound care was then shifted to just foam dressings, and as seen here, the patient updated me through social media, and the pictures here show improvement of the wound until it closed from day 47, day 73, day 82, and day 92. At day 92, you could only see just a small patch that is a bit open, the size of a 10 centavo coin. But eventually it closed. At home, they were trained to do local debridement, and while also at home, the patient was allowed to weight bear but on a cast boot, and was allowed full weight bearing as long as the patient was on a cast boot. And patient already has a plantigrade foot, but with limited ankle range of motion. The ankle was very stiff. Okay, so that is my case. So for the questions for the panelists, would you have done, or to anyone, especially the foot and ankle guys, you have done the coverage procedure in conjunction with the initial reconstruction, or would you have, when the flap failed, would you have done a second coverage procedure, or just manage it conservatively and just allowed to granulate? What are the other options? Maybe Sir Denver can elucidate on how his cocoa patch could help, or would you have continued using NPWT? And yeah, this case was actually had some limitations due to the pandemic here in our country. So thank you very much.
Thank you.
Thank you,
That's
Doc.
probably Dr. Ronquillo, any thoughts?
It's a bit difficult yung tanong ni Gachi sa case to case sorry, nag-echo yung naririnig ko. Where was I? Yeah, it really depends on the soft tissues as well. Sometimes I have to make sure that I have eradicated all the infections present. But then again, it depends on the AP himself. If you think that's the most viable thing to do or the most reliable thing to do, just to lessen the duration of healing, etc. I think they did. Dachi and his guys did a very good job with this one. There's no such thing as a very good surgeon when it comes to this. It's a case-to-case basis, and kudos to Dachi for that.
Thanks,
And no matter
Boss
what
Gach.
dressing, no matter what dressing you use, it still depends on anatomy and physiology with this one. So it's a close watch. You have to closely watch these patients.
Okay. For me, Gach, no, for foot and ankle guy, no, I had a similar case, very similar, like we talked about last night. My learning curve from it, one, stabilize everything. I think having an X fix, not because of the fracture, but for the soft tissue stability would have helped. That's one. That's one thing I learned. Another is if I'm gonna do a skin graft immediately, I'll probably wait for 2 to 3 weeks before I try to do that. Because the surrounding tissues might have been compromised pa rin. That's why probably too early movement of the soft tissue could affect. Yun lang. That's my thoughts, sir.
I agree.
Boss Denver,
Boss
Yeah.
Denver.
if you have any thought about it.
Tingnan niyo po yung slide na po. Sa wound care naman, most of the time yung tinitingnan po namin is yung financial capability. Sometimes, most patient, like when we catch yung mga, alam mo mga pumisa pag darating na lang sa atin na worse na yung sugat. No? Ang while buying time for them to have a funds sa mga procedures as well as kailangan i-consider din natin as practitioner kung ano yung budget nila. Like, pag kanyari, dati may nagsabi sa akin na doctor from St. Luke's, what do you need to say na mawawalan kami ng trabaho because of product? No, hindi. Kumbaga, while preparing for the wound bed, kasi ginagamit rin siya yung patch for skin grafting, for maging maganda yung granulation niya, as well as pagka kadalasan ginagamit nila, dakies, sometimes yung graft hindi po nagtitake eh. Tapos ang paggagamit pa ng mga silver dressing, like the usual, is mga hydrofiber dressing, may naiiwan na particle, yun po yung nagiging problem. Pero to totality of it, yung financial constraint minsan ng mga pasyente, kasi not all patients are capable na outright, kinagawa sa kung kailangan ng surgery, may pera agad sila. Pero while buying time for such procedure, yun, may options sana tayo na maintindihan natin yung capability ng patient to have a good managed or treatment.
Thank you. Boss Rendell?
Yes, I have a question for the boss, Sir Denver. Is a cocoa patch, can you use a cocoa patch as a dressing in replacement of hydrocolloid dressings for mga donor sites from skin graft? Kunyari, pinagkunan ng skin graft, yun na lang ang gamitin.
Actually po, Doc, yes po, Doc. We're using it for mga actually graft site. Graft site ang ginagamit po. Graft site. Sa donor site, hindi develop po po, Doc, yung exacto for the graft site. We have the initial study before ng sa graft area, pero mabilis siya pag Zimmer ang ginamit, better po siya. Pero pag yung Humvee, medyo mahirap po mag-heal pag using cocoa patch. Pero pag Zimmer, mabilis po siya. 1 week time or less, okay na po siya.
Okay.
So, pasensya na, but we have to cut Maganda sana ang discussion, but I think the next presenters are ready. Thank you, Denver. Thank you, Dr. Ronquillo. Thank you, Lendel. Thank you, Dr. Melia, for being here. And POA, thank you very much for having us. Thank you.
Thank you.
Thanks, Tubes.
Very much
Thank
po.
you, boss. Thank you.
Thank you, Philippine Orthopedic, Wound Care, and Diabetic Limb Society, our speakers and moderators. Please do not forget to fill out our evaluation form. You can find the link in the posted in the chat box. Let's take a break with a snack symposium brought to you by 3M. It will be moderated by Dr. Anatalia III with our guest speaker, our friend from Singapore, Assistant Professor Francis Wong Ken Lin, and Dr. Wilbur Belieca.
Hi, good afternoon. Is my audio clear? I can hear. Is my audio clear?
Yes.
Good afternoon, everyone. Hi, we'll be having a stock symposium courtesy of 3M, one of our diamond sponsors. And today we'll be hearing from our friend from Singapore, as well as one of ours. But first, let me introduce to you our friend from Singapore, Assistant Professor Francis Wong Ken Lin, Francis Wong Ken Lin, and he is a consultant in the Department of Orthopedic Surgery, an assistant professor in Duke NUS Graduate Medical School, and a clinical lecturer in NUS Yung Lu Lin School of Medicine. He is also the chair of the Wound Committee in Sengkang General Hospital, as well as the campus service chief of Sing Health Duke NUS Cell Therapy Center in Sengkang General Hospital. Today he will be talking about, his topic is about towards better recovery of complex lower limb wounds, multidiscipline. It's a team orthopedic podiatry multidisciplinary approach. And so he'll be giving us a lecture, and then after that will be our lecture from our friend from Bicol. Is Dr. Wilbert Belieca, an active consultant in Regional Orthopedic Center of the Bicol Medical Center, and heads its developing diabetic foot and wound care unit. Currently, he is the training officer of the Department of Orthopedics and Traumatology of Bicol. So we'll be having the two lectures, one after the other, and after that a Q&A portion. So and then you may type your questions in the chat box so we can entertain them. So without further ado, I would like to welcome Assistant Professor Wong Ken Lin Francis for his first lecture.
My name is Francis from Singapore, and I am the program lead for my hospital's multidisciplinary team for diabetic foot wounds, and I'm also the chair of the Wound Committee in my hospital. Today, I would like to share with you our experience and methodology of how to get better results and towards better recovery of complex lower limb wounds using our TOP multidisciplinary approach. This is the disclaimer. This is the outline of my talk. Let us start with the introduction. As we all know, patients who present to the hospital with DM foot infections are of a lower socioeconomic status, they are sedentary, and have poorly controlled diabetes mellitus. Our latest figures in Singapore show that 1 in 3 diabetics do not even know that he or she has the condition, and 1 in 3 known diabetics do not know enough to control the condition. Treatment for this group of patients are typically associated with prolonged duration and moderate and poor results. This, in combination with their socioeconomic profile, leads to poor compliance to the treatment regime. One of the main reasons of this poor compliance is that they have to return to work to support their families, and they cannot afford long durations of treatment. Many of them, unfortunately, then end up with a loss of limb with a below knee amputation or above knee amputation. In Sengkang General Hospital, we decided to combine the highly validated multidisciplinary approach with aggressive early management with innovative technologies such as using MPWT-ID as first-line therapy for wound care as shown here, and providing a one-stop shop for patient journey enhancement. This has led to better outcomes for our patients, which I will elaborate later. Our main objectives are to reduce the total duration treatment and an early functional return to community, and this thus relies heavily on our aggressive early management with therapies that can drastically improve the outcomes for the patients. Let us now look at TOP in SKH. Our aims thus in this hospital is to create a multidisciplinary team that is truly multidisciplinary, i.e. coming together at the same time to review the patients together with a combined decision to allow for a best outcome for our patient. We also aim to look into complex lower limb wound debridements, not just diabetic foot wound patients, but also complex lower limb wounds above the knee. We are keen to provide a one-stop shop for patients by bringing all the disciplines to the patient in one location and giving the patients a place to call home. And lastly, we want to enhance the patient experience with continuity of care by the same team from admission to discharge to home. As we all know, the 4 pillars of diabetic foot wound management includes controlling the infection, settling the vascularity issues with the patient to allow for good oxygenation, of course controlling the diabetes, and offloading for pressure ulcers. For us, we build on that to have our paradigm for diabetic foot wound management and limb salvage in Sengkang General Hospital. And what do? First things first, we acknowledge that a lot of these patients have infection, and therefore early infection control is key, and we employ radical, decisive debridements to remove all the dead tissue as fast as possible. For this, we have our orthopedic surgeons and our ID physicians working together to surgically debride and create the best antibiotic regime for our patients. Our nurses and podiatrists are actively involved in managing the wounds with dressings and negative pressure wound therapy. In vascularity, we understand the need for having good vascularity for wounds to heal, and therefore we actually use below knee or even below ankle angioplasties to enhance the outcomes of our patients. For these, we have our intervention radiologists and our vascular surgeons to help us at times. Thirdly, as we all know, if the wound is exposed to the conditions of the air and the environment, with time they will get secondarily infected. And therefore, we have aggressive early wound coverage. And if need be, and if the wound is big enough, we flap them. And with this, we require our plastic surgeons to be on board to help us with this aspect. Of course, not forgetting medical aspect help, such as the dietitians to help to control the diet, and the endocrinologists to control the diabetes mellitus and other conditions that will affect the wound healing. And last but not least, our podiatrists offer wound healing practices such as that of offloading to allow for the wounds to heal. Our very first multidisciplinary team, which was called Team Orthopedic Podiatry, is a multidisciplinary wound and lower limb salvage service in SKH. Initially, we had orthopedic surgeons, podiatrists and nurses, and we have combined clinics, multidisciplinary ward rounds, and we even have a procedure room to perform day surgery to reduce the chance of readmissions. Together, we form a network that brings patients from the inpatient to the outpatient to home. We also have in our network infectious diseases consultants and endocrinologists that are co-managing the patients. And this is our management algorithm. When referred and when surgery is needed, we will intervene early with surgical debridements and application of MPWT ID or any negative pressure wound therapy in the OT. We will monitor the wounds with our multidisciplinary ward rounds. And once the patients are ready for outpatient care, we continue to follow them up in our clinics. And when patients require a debridement of the wound, we have a day surgery suite to debride the wounds and to keep them from readmission to hospitals. As you can see, with these wounds that are being healed, we needed to upgrade TOP and we had our plastic surgery addition because we need to have early skin coverage options and early flap coverage options when the wounds are big. And therefore, our TOP version 2, which is now called Team Orthoplastics Podiatry, has our plastic surgeons on board. As you can see, the algorithm is the same, but they join us for inpatient surgeries, our multidisciplinary rounds, our clinics, and also in our day surgery. Shown here is a picture on the far right of our team together at our day surgery suite, which is actually a converted room from our clinic where our plastic surgeon is performing a SSG or split skin graft in the clinic with local anesthesia. For handling major complex lower limb wounds, we also moved our orthopedic specialty nursing team, which is our wound nurses, and their roles are to handle complex orthopedic wounds, making sure patients are immobilized correctly, and of course patient education as well. Let us now look at MPWT as a first-line therapy. So first of all, why do we use MPWT in the first place? We want to have a watertight seal to prevent bacterial contamination. We want to stabilize the wound for healing. And of course, as all papers have shown, negative pressure will allow for faster granulation and faster healing of the wounds. Prior to having MPWT, what are some of the problems that we faced? Number one, the traditional vac requires us to change a vac every 3 to 4 days, and there's no cleansing of the biofilm and the bacterial bioburden within the wound. And this required us for bringing the patients in for repeated debridements in the OT. Objectively, the health services resources are also drained because the patient which need more debridements in OT would have increased length of stay, have increased cost of inpatient stay as well with increased OT visits, and eventually leading to a longer duration of MPWT therapy. The next question that we like to ask ourselves is, how do we decide how clean our wound is? Is it truly clean? In this case, we have to use cancer surgery principles with radical excision. Is it equivocal, where when you cut, there are some erythema around the excision margins and the bases are still equivocal and you're not very sure whether you have gotten a clear debridement done? And of course, if it's dirty, where you know that you're bringing the patient back after 48 hours, even though you're in theatre already debriding the wound. Let us look at this infection of a diabetic foot, for example. Clearly, you have a first metatarsophalangeal joint infection with surrounding erythema and underlying pus collection, and this is an angry looking foot. The concept of a truly clean wound, you have to radically excise it before the infection spreads. Over here, you see the loss of the first and second ray with the excision of the first metatarsal. In this case, we apply the truly clean principles, and you're quite sure at this point of time there are no infection left because even the satellite infections have been cleared off with a radical excision. However, most of the time we don't do that, and we essentially just remove maybe the main toe, the big toe in this case, and we will have some equivocal regions where the skin has some erythema around the excision margins and the bases are still quite equivocal. But your aim is to try to preserve whatever you have and to try to preserve the wound size so that you don't have to require a major limb reconstruction. A wound is considered dirty when you look at the wound and you see, there's still pus coming out at the edges, there's very unhealthy bases and the edges are getting necrotic. So therefore for us, when we assess the wound, we assess it first of all by size, where small wounds can be dressed with topical dressings, larger wounds can be nursed with negative pressure wound therapy, and so on. But we also then take into consideration the assessment of the wound clearance, as I mentioned before. Is it truly clean? Is it equivocal? Or is it dirty? If the wound is truly clean, we can proceed to routine negative pressure wound therapy as a first line. If the wound is equivocal and you're not very sure whether you have done a great job in theatre, then we will advocate the use of MPWT-ID as a first-line therapy, sometimes with the use of reticulated sponges, in this case it would be cleansed choice sponges from 3M, to help to constantly clear the wound debridements via in situ debridements and washouts using the machine, so that the wound will be cleaner faster. Once the wound is truly clean, we will then revert back to the routine MPWT for granulation and wound healing. Here are some case vignettes from our TOP side. So first of all, this is a case example where we use MPWT-ID as a first-line therapy. This is a 45-year-old lady with a left foot plantar wound that was not healing well and was offered below-knee amputation by 2 surgeons. Here are the x-rays and MRIs, and there are signs of osteomyelitis with extensive soft tissue infection and a deep tissue cultures group pan-sensitive pseudomonas. So we proceeded to surgically debride the wound and applied Veriflow therapy, the MPWT from 3M. After 3 weeks of Veriflow therapy, the wound is getting healthier, and we continue another 5 weeks of Veriflow therapy with a low concentration of a diluted iodine solution as the instillation fluid. And after a total of 8 weeks of Veriflow therapy, the wound has surfaced, and then we started on topical dressings, and the total duration was 3 months, and the foot was safe from amputation, making her a happy and grateful patient, and to this day, her foot is still great. Here's another case example of a left foot wound that needed limb salvage. The left foot wound infection was uncontrolled, and the patient was offered BKA. What we did was a thorough debridement of the necrotic tissue and the infected tissue, and then we started Veriflow therapy with a cleansed choice sponge. This reticulated sponge allows for constant in situ debridement of the tissues to keep the bowel burden low and to allow healing to take place faster. 4 weeks of Veriflow and cleansed choice therapy was used. The wound proceeded to granulate well, and we downgraded to routine VAC, and the patient's wound was healed after 4 months by granulation. Another innovative method that we have used MPWT-ID is to use it as an irrigation channel, like in this case of a deep midfoot plantar abscess. We use a small incision to debride the abscess, and then use Veriflow therapy as an irrigation channel to wash the wound constantly. The patient had 2 weeks of Veriflow therapy, and the wound looks clean with no more pus discharge. The inflammatory markers were also downtrending nicely. We then sealed the wound well with a handheld mechanical pump vac therapy system, which is SNAP, for 2 weeks. Our technique of modifying the MPWT to suit small wounds like that of the rehabilitation wound, which we call the waterfall technique, has been published, and the usage of Veriflow as an irrigation channel has also been published in wounds as well. With our plastic surgery colleagues joining us in the forefront, rather than reaching granulation and topical dressings, what we have done now is once the wound is ready for SSG, we now have our plastic surgeons to perform early SSG on our patients to seal the wound earlier, and this has resulted in great outcomes for our patients. So here's an example of a complex wound in a difficult area, which is the popliteal fossa, or the back of the knee. We have a 49-year-old Malay female who is a school chef with diabetes, hyperlipidemia, and already had previous amputations. She admitted to us with right posterior thigh necrotizing fasciitis, and she underwent surgical debridement twice, but was unable to control the infection. With our plastic surgery colleagues, we went in together to debride the wound, and post-debridement, we applied Veriflow cleansed choice dressing on the wound to keep the wound debrided and clean, and to keep the bowel burden and the bacterial burden in the wound low. So as you can see, with the use of Veriflow therapy and a cleansed choice sponge, the wound has improved tremendously, and granulation tissue is seen, and there are no further pockets of pus seen in our necrotizing fasciitis wound. And eventually, as you can see, our plastic surgery colleagues has then shrunken the wound with surgical debridements and surgical closures, and then put on a split skin graft for our patient. And this is her 1 month post skin grafting, and she's back in the community, and she essentially had gone back to her job, and she's happy, and she's remained disease free till now. How about bone and joint infections? This is a case of a diabetic foot patient who suffered septic arthritis and osteomyelitis of the ankle, and was again recommended BKA by several surgeons. We debrided the wound and curated the infected tissues. And then we started the wound on MPWTID with Veraflow. And what we did was we tunneled it through the joint on both sides of the ankle with a connecting pad and a Y connector. Once the wound starts to granulate, we then converted the Veraflow to regular VEC therapy. At the end of 4 weeks, the wounds are clean and well granulated. We then referred this to our plastic surgeon colleague, who then provided muscle flap coverage. At 2 months post-flap and 4 months post the initial operation, the patient has his limb salvaged, is walking well without any aid, and his limb has been successfully saved. Let's look at some of the clinical and functional results of TOP. As a subset results, we decided to look into our collaborative service that mainly involves the orthopedic surgeons and orthopedic nurses, plastic surgeons, intervention radiology, and podiatry. And we looked at 50 patients with 52 diabetic foot wounds that were followed up from 2020 to 2021 for a year. And in our patients, we have 50% of our limbs with peripheral artery disease, and 70% of our limbs actually receive angioplasty. The average HbA1c is about 8.9%, which can show that they are poorly controlled diabetes, and the average age is about 60 years old. About 70% of them went through secondary closure, 27% of them went for SSGs, 35% went for local flaps, and 21%, which is 11 patients, underwent free flaps. And the average duration from surgical debridement to coverage is about a week, whereas if you compare this to historical cohorts, we are looking at an average of about 2 weeks. The mean duration of hospitalization is 11 days, and if you look at that, it's a bit longer than our median hospitalization overseas because we are doing flap coverage for our patients. So what are our results? As we look at our service, we realize that we have 96% return to pre-morbid ambulatory status with a mean duration of 3 weeks after wound coverage. And the mean duration of the first ambulation is under a week post-operation. What it means is that our patients are going back to work faster, are going back home faster with a functional outcome. 96% of our patients achieve complete wound healing with a mean duration of 2 months, and when we say complete wound healing is when they do not need any dressings anymore, i.e. patients can go back to work without worry, without any patches on their skin after 2 months. There was a 4% death due to contralateral ischemic limb and 1 aspiration pneumonia. However, there was 0% major amputation either below knee or above knee. And for wound recurrence, we have 8%, but this is very common looking at our diabetic foot patient profile. So as you can see, in Sengkang General Hospital, we pioneered what we call the orthoplastics approach in our multidisciplinary team with early aggressive debridement for our patients, early revascularization, early wound coverage. And this, being aggressive, helps. This reduces the duration of treatment and improves the functional outcome of our patients. Our patients, again, thank you for listening, and we thank you for listening to us. And we hope to see this kind of approach being seen in other countries to help patients all around the world. Thank you very much.
Thank you very much, Assistant Professor Francis. And Thank you for sharing to us your experience in Singapore with the KOP or Team Orthopedic Orthoplastic Podiatry Multidisciplinary Approach. Now, let's go to our local speaker, our friend from Bicol of South Luzon, and he will be talking to us about negative pressure wound therapy, our local experience. So to introduce to you our next speaker, Dr. Wilbur Belica.
I'm Dr. Wilbur Belleca. I'm going to talk about our local experience with negative pressure wound therapy then and now here in the Bicol Medical Center Regional Orthopedic Center. Bicol Medical Center is a 1,000 bed capacity BOH retained tertiary and referral center in the Bicol region. This will be the outline of my presentation. First is the statement of the objectives, followed by case presentation with modified negative pressure wound therapy and VAC therapy system. Afterwards, discuss briefly the mechanism involved with VAC therapy and share with you the results of our observation. The objective of this presentation are as follows. Present the evolution of NPWT practice in our institution, present sample cases using the modified NPWT and the VAC therapy system, present our experience and observation and its effect in outpatient care, especially in wound care management. Some time ago, we're using a modified NPWT setup to manage both acute and chronic wounds that needed negative pressure wound treatment. This consists of a suction machine, a suction tube, an NGT, a gauze, and a clean wrap. If the occasion permits, we are able to use foam dressing and a sterile incised drapes if available. Here are some cases that we manage with a modified NPWT. This is a 33-year-old male who was figured out in a vehicular accident, sustained an open fracture of the tibia. He was initially managed with external fixation and fibular graft and was sent home. After 2 weeks, he came back with an infected wound, extensive debridement was done, and started with modified NPWT. Debridement and serial application of modified NPWT was done. Skin necrosis was encountered on the 2nd week and infection still persisted. After 4 weeks of treatment, infection was controlled. The wound bed started developing good granulation tissues and epithelialization. This is another case where we use modified NPWT. This is a 19-year-old male who was figured out in a vehicular accident, sustained an open fracture of the tibia and fibula right, underwent debridement, application of external fixator, and placed in a modified NPWT setup. On the first NPWT, there was still some necrotic tissues noted with signs of infection. Repeat debridement and modified NPWT was done. On the 2nd week, we were able to control the infection and achieve a good wound bed. After having a good wound bed, we proceeded with the wound coverage. The anterior cortex of the tibia were debrided, followed with a muscle flap and a split thickness skin graft. On follow-up, there was a good take of the skin graft. Now, we are able to use the VAC Ultra therapy system with all of its complementary accessories. We are now using this VAC machine to manage both acute and chronic wounds. These are some of the cases we have applied NPWT using the VAC Ultra machine. A 36-year-old male who was figured out in a vehicular accident, sustained an open fracture of the tibia. Immediate application with NPWT using the VAC Ultra system after debridement and application of external fixator. Another case, a 33-year-old male with a mangled extremity due to vehicular accident, sustained an open fracture on the knee with a MES score of 9. In the OR, a severe comminution of the distal femur and proximal tibia with an associated vascular injury was noted. An open above knee amputation was done, and a wet to dry parachute suture dressing was initially done. After the first dressing change, grossly the wound bed was not looking good, with a visible slough, necrotic tissues, and possible infection. Repeat debridement and application of NPWT using the VAC Ultra machine was done. After 4 days with VAC therapy, there was a good-looking wound bed, so we proceeded with the closure of the stump. Another case involves a 33-year-old female who sustained multiple fractures of the left lower extremity secondary to vehicular accident. Patient underwent debridement application of spanning external fixator. 2 days after, the leg developed infection and became cold and cyanotic. Eventually, patient ends up with an above-knee amputation. An open stump above-knee amputation with immediate VAC therapy was done. 4 days after VAC therapy, there were good viable tissues with granulations and no sign of infection. Closure of stump was done. What makes NPWT effective? Its mechanism. The mechanism of action behind NPWT or VAC therapy is due to the macrostrain and microstrain brought about by the effect of the negative pressure on the wound bed. Macrostrain draws the wound edges together. It removes exudate and infectious materials, promotes perfusion, and reduces edema, while microstrain stimulates cellular activity that results in granulation tissue formation in the area where the foam is in contact with the tissues. These are our observations with modified NPWT. The problems we commonly encountered were leakages, compromised sterility, and difficulty to maintain ideal pressure. There is a need for frequent visit to monitor the setup to ensure optimum function. You have to turn the machine on and off if you want to do intermittent mode. However, with diligence, despite some obstacles, although it may not be the ideal setup, modified NPWT still shows some good results and benefits. One just has to be patient and vigilant. With VAC Ultra therapy system, we were able to address the difficulties we encountered with modified NPWT. With less leakages, sterility is maintained, and application is easier. With programmable mode and adjustable pressure setting, nursing visits are lessened, and duration of treatment is shorter. There is also an installation therapy option. Although with the high cost per application of VAC therapy, lesser patient hospital stay and early recovery period still proves to be more cost-effective overall. In summary, modified NPWT is still a viable and effective alternative options for those who do not have a VAC machine. With our experience with the VAC Ultra therapy system, it is easier to apply, it shows superior clinical outcome, and is more cost-effective. Thank you very much for watching and listening.
Thank you very much, Dr. Wilbur Belica, for that informative lecture and showing us that the experience here locally in using negative pressure wound therapy is somehow at par or a technology that's also being used here in Singapore. So we may start question and answer portion of our activity for today. And I'll start with the first question to Dr. Francis.
Hi.
Hi. Since we're talking here about a multidisciplinary approach, like teamwork between orthopedic surgeons, podiatrists, as well as a plastic surgeon, I'm curious about the follow-up of the patient when after you have referred the patient to a plastic surgeon, and then later on, since this is our patient to start with, how do you do about with the follow-up?
Hi, thanks. First of all, thank you very much for the invite. The answer is very simple. The multidisciplinary team does not end in the inpatient. So in the outpatient as well, we have the same setup, just that the patient comes over to the clinic where everybody sees the patient again. So in Singapore, for Sengkang, the orthopedic surgeons are the hosting department. So patient comes to our clinic, but we actually have also our plastic surgeons sitting with us in our clinic as well to see these patients together. So it is essentially, when we talk about multidisciplinary, we want to have a same team that sees the patient from start to end, because, you know, for all these DFUs, diabetic foot ulcer or DF patients, you really need to instill that confidence in them. There is the same team that will follow you from start to end to save your leg. If not, a lot of them just get jaded and don't come back, right? They just have non-compliance. So in short, the answer is the multidisciplinary team sees the patient from inpatient to outpatient to discharge. Yeah.
Thank you very much. We're just waiting for some other questions that may come in, and while waiting for other questions, I'd like to ask also Dr.
Again, Dr. Natalia.
I'd just like to ask Dr. Belica, how about in the Philippine setting, have you also embraced the practice of multidisciplinary, like in your use of negative pressure wound therapy? How far have we gone if in the practice of wound care multidisciplinary approach?
In our institution, since we are still in the initial phase of the development of our wound care center, the orthopedic department is the one primarily handling the wound care unit. This is in cooperation with some of our nurses. But there is still a plan to, once the wound care center is fully developed, this will now include a multidisciplinary approach, including the plastic surgery, the endocrinologists, especially for our diabetic foot cases. So for some institutions, I believe they have already established a multidisciplinary approach with wound care management.
I understand. So let me just check. And then follow-up question with for Dr. Francis, and actually for both doctors. Aside from negative pressure wound therapy, are there other modalities that you currently use, like the use of ultrasound assisted wound debridement? What is your take on this? Can we start with Dr. Francis?
Yeah. Actually, it is actually my main weapon now when I do debridements. So we use the Misonics, which is an ultrasound debrider. We find it quite useful, especially for chronic wounds that has a very thick layer of biofilm. And also, for most of my debridements now, I actually do use it. It seems to, I mean, anecdotal evidence, of course, but it seems to really help to reduce the number of debridements. I mean, as surgeons, right, what we do, you have a wound, you take a curette, maybe a clot curette, you curette it. And then you just see good, healthy bleeding, and you think you got a nice, clean base, for example. The use of the ultrasound debrider actually essentially goes a layer deeper. What I found, I go a layer deeper, and it really helps to remove or helps to dislodge the satellite infective particles, especially in the layers of the fat. Let's say if you're doing a foot or even the leg, those in the fat layers, it really helps in dislodging and melting away the unhealthy fat and also the unhealthy muscle. So for me, we use it quite regularly right now. In fact, I just came to a case and I just called for it as well. So, but yes, there is a problem of cost. It is expensive to use it. So we have to be quite judicious in using them in order not to increase healthcare costs. So generally we use them for very severe wounds and all very chronic wounds. Very simple. Severe in the sense that it's a necrotizing fasciitis that you really need to do a good debridement, and you're trying to do limb salvage surgery where you're trying to preserve soft tissue. So with whatever you have at your margin edges and the base, we will use that. And for chronic wounds that of course has failed 2 to 3 surgical debridements from my colleagues, when they come to my hands, I will use the Misonics or use the ultrasound debrider to actually curette and to clear the wound thoroughly. Following that when I put on my MBWT or my MBWT ID, the results are going to be much better because the next time I open the wound, it is really granulating. So therefore, the entire process is shortened by weeks. So that's our plan. So I think the thing about having a multidisciplinary team and using the products that we have here is really to shorten the time to heal. Because no matter what, if let's say the wound is left there for some time, even if you negative pressure for a long time, for example, once you open the wound, you wash it, you close it up with another negative pressure, there's always a chance of biofilm, there's always a chance of secondary infection. So I think right now in Singapore, we are pioneering the point of being aggressive, whereby you really clean it up very well, and you put on this negative pressure therapy systems, and you let it you start the granulation system very well, start the granulation process well, the healing process well, and you close it well, you close it fast. That's why for us, we flap it, we flap our patients if needed. I know it's a bit scary to sound like how we are flapping diabetic foot patients, but it can be done. If let's say you do a good debridement, as I mentioned, like with ultrasonic debriders, with MPWT ID, you maintain that base. You're very confident that the wound is clean, and we flap it. So we actually reached 50 flaps right now this year with our patients, and none of them have failed. Because number one, the wound is clean. Number two, the flap itself is done by plastic surgeons who have a lot of experience in flaps. Number three, in the multidisciplinary team, our vascular supply is quite important, right? When you do a flap, we actually discuss with either our intervention radiologists or with our vascular surgeon to decide, look, which are the vessels that you can open. And once you can open, we will then proceed with the flap of choice with the available blood vessels that we have. Yeah.
Dr. Wilbur? I think Dr. Wilbur had problems with connection. But anyway, we're gonna wrap things up. And first of all, thank you very much, Dr. Francis.
Thank you.
And Dr. Wilbur for sharing to us your experience through very excellent lectures and presentation. I really do believe and agree that the use of negative pressure wound therapy has made our lives so much easier, especially in the care of acute and chronic wounds. And hopefully that through this technology, we'll be able to make advances in caring for this chronic and acute wounds. And hope to meet up with you, Dr. Francis, and see you very soon. And hope to get more tips from you, especially with regards to wound care and at your local experience. So thank you very much, everyone. And I hope the lectures have been very fruitful. So thank you and good afternoon.
Thank you. Bye-bye.
Yeah, once again, thank you very much, Associate Professor Francis Wong.